We do have closed captioning, however, available, and there's the recording. You'll get a little message saying that we are starting to record. We do have closed captioning available in English only, so you should be able to click the little live transcript button in the bottom right-hand corner of your Zoom screen, and you should get an automatic CC transcript there for you. So with all this in mind, I'm hoping to start us off in a I think a reflective way this morning, this afternoon, wherever you are. We really are coming together today from so many different places and locations across the country, across Turtle Island. And we do work in a sector whose goal, the harm reduction sector, is to really address social harms. And we really must recognize that sort of the production of these harms are really rooted and coming from a history of colonialism and its enduring practices, institutions, and ways of thinking. I would sadly say colonialism is alive and well with us today. And so we really need to kind of, I think, shift and recommit to working in ways that sort of try to sort of shape these institutions and practices. I know for myself, I'm based in Jojage, or so-called Montreal, and the sort of custodians or caretakers of the land are seen to be the Ganagahage Nation, but it's also seen as a meeting place for a number of other Indigenous nations. I welcome you, if you're wanting to share where you're coming from today and why you're here and what brought you to this webinar. I know this is, for some, not new information, but we would welcome you to join us at the National Safer Supply Community of Practice. There's a little bit of information about our goals and what we do. Really, our goal is to sort of scale up and expand safer supply programs across the country, and we do that through capacity building and knowledge exchange. We also will have a certificate of attendance available. So for anybody who's wanting a certificate to say that you attended the event, we're going to be sharing the link closer to the end of the webinar, so stay tuned for this. And I guess this really brings me to the intro, to turn it over to you, Frankie. Why are we having this panel? I think a lot of us on this call, a lot of the people who are the panelists and the participants, we know that this is a very timely, very relevant conversation to be having, and sort of really wanting to recenter the voices of people who use drugs, who are the real experts on safer supply. And so I'm just really, really happy that we were able to make this happen in such a short time frame. Frankie, I'm gonna stop sharing my screen, and I'm gonna let you take it. All right.
Awesome.
Enjoy.
So hello, everybody. I'm very excited to be moderating today's panel. I think it's going to be a really awesome discussion. Like Alex said, my name is Frankie. I use she, her pronouns. I am also a community health worker for the Safer Supply program at Street Health, as well as a drug user myself. I'm coming to you from Toronto, which is Treaty 13 territory. It's surrounded by Treaty 13A, Treaty 20, and Treaty 19, and we fall under the Dish with One Spoon Covenant. And it's the traditional territory of the Wendat, the Haudenosaunee, the Anishinaabe, the Mississaugas of Credit River, and should remain under their full jurisdiction. I also just want to share that my role as the moderator is to keep people on time. So if I redirect at any point, I don't mean to interrupt, but if we get off topic or if we need to switch topics for the sake of time, I will do so lovingly. And I'm here to support the panelists in sharing. I think we're all super lucky to be here today and to be able to hear what folks have to share. I also just want to say, I roll my eyes a bit because I feel like there's been lots of discussion about this, but I think that it's a bit of a stressful time, a little bit of yucky time with Vincent Lam's article in the Globe having come out over the past weekend. And I think what was glaringly absent for me in that article was a reflection on the harms that exist within the medical system. And I think what was even more glaringly absent was the voices of drug users. And so I'm, again, so excited to have this panel. And I think that the timing is perfect for it, because we acknowledge that safer supply in its current iteration is certainly not perfect. There are many issues and challenges and barriers that we experience with safer supply. But we also acknowledge that it has many benefits, and we are in a crisis, and we need as many options as possible for drug users to stay alive. So I want us to have a very fulsome and complex conversation today, both acknowledging, some of the barriers and the things that, we don't like about safer supply, but also acknowledging everything that we've gained, or the things that we benefit from with safer supply. So that said, we're going to go into some introductions for our panelists. So let's start with Angie. Do you want to start? You're on mute, Angie.
There we go. I'm unmuted. Hi, I'm Angie. I've been an addict for 30 years. I'm on safer supply. I've been on it for like 4 months now. What else? I'm from Kitchener, Ontario. We have a great support team here. They're amazing. They're my angels. I'd probably be dead if it wasn't for them. So with that being said, that's all I have to say right now.
Phoenix, do you want to go next?
Good morning. My name is Phoenix Beck Mcgreevy. I'm here as an independent member of the National Safer Supply Community of Practice. I have been a quote-unquote hard drug user for about 23 years now. I am engaged in a number of academic research projects on safer supply here in Vancouver, and I'm really glad to be speaking here today. Thanks all for listening.
Thomas?
Me? Oh, hi. I'm Thomas Noble. I'm in Fredericton, New Brunswick. Yeah, right now. But yeah. I'm an artist in residence at the Riverstone Recovery Center, and working towards being a peer support worker. And I have lived experience with venous drug use with crystal meth, every kind of opiate, basically cocaine, and I've also used a bunch of psychedelics and psychotropics, and yeah, that's it.
Thanks, Thomas. Ashley?
My name is Ashley Smoke. I come from Alderville First Nations Indigenous Reserve. I'm a community member, drug user, advocate, and yeah, I'm just excited to be here, talk about safe supply, because I've been on it for now a year and a half.
Liam? You're muted, Liam.
Hi, my name's Liam. I'm with the South Riverdale Community Health Center, and I've been a hard drug user for a long time. And I'm on the safe supply for 3 months now. And I guess that's about it.
Thanks, Liam.
Thank you.
Hi, Can you hear me?
Yeah, we can hear you.
Okay, so I'm from Ottawa. I work at Somerset West Community Center as a community worker, basically a peer. And yeah, before, like, I'm on the Safe Supply program as well at another facility. But yeah, it's completely changed my life. Like for like the 20 years prior, I basically lived like wherever I could, and like sometimes on the sidewalk, and basically sold drugs and just made my survive day by day, right? And then it's one of, I guess it's important to mention that I was the first patient on Safe Supply in Ottawa. I just explained the data that we got in Toronto to my doctor, who was very like, he was like one in a million. He listened to me. He actually listened to me. He didn't tell me what I needed. He listened to what I needed. You know what I mean? And so that started off the Safe Supply movement in Ottawa, as far as I'm concerned. And so yeah, things are going, if you like, I wouldn't even, I wouldn't even be on something like some meeting like this if this was 6 years ago, you know what I mean? So thank you.
Yeah, thanks, Steve. That's actually a great segue. We're gonna now talk about some benefits that we've experienced being on Safer Supply. I just want to remind panelists to please use your raise hand function if you want to say anything. So yeah, let's kick off the conversation. Whoever wants to start by sharing some positive experiences. Go ahead, Angie. You're muted.
There we go.
There you
That's
go.
better? Okay. I find that with Safe Supply, I don't have to go run and find drugs anymore. I don't have to, I'm not sick all the time. It's helped me just have a bit of a better life, like not having to, just be around people that I don't want to be around. Just like not happy at all in my addiction, right? So it's helped a lot that way, I can stay at home and just chill, and I don't have to go find that fentanyl or whatever, if I want to do a toke, I can do a toke, and I'm okay with it, right? It's not about getting unsick. It's about, just if I want to get high, I can get high, right? So
Yeah.
Yeah.
It's about that stability and consistency, right?
Absolutely. Yeah.
Phoenix, I see your hand.
Yeah, so I'm on OAT as well as a small dosage of hydromorphone that my doctor has been kind enough to prescribe under the risk mitigation guideline prescribings here in BC. And while I find that it has limitations for sure, it's definitely, the hydromorphone is a good way to fine tune the dose of OAT. If I'm feeling a little more sick, I can take a few more hydromorphone. If I'm feeling good and I'm using that day, I can reduce the hydromorphone use. So it really just serves as a method of fine tuning the level of opioids that are in my system. But I do agree with Angie, it really, if you've got that baseline level and you don't have to go out and seek the street drugs if you don't need to, it really helps to just provide a base level of stability, I find.
Mm-hmm. Mm-hmm. Go ahead, Ashley.
One of the most benefits that I have is my relationship with my team and the wraparound services that the CHC provides. I mean, I lost my benefits and they started paying for my meds. So I think that's pretty that shows that they actually care. And also with the supply being so toxic of street drugs, I think it's nice to be able to not have to worry if I'm gonna get a bad batch. I like being able to choose my plan of care and
Mhm.
like the different options. I mean, I think I've tried so many OAT options and all kinds of safe supply options now, and I've tried so many mixtures, and I'm just thankful that there is that ability to like have like an individualistic treatment plan and to like lead it
Mhm.
instead of having a doctor lead it.
Right.
And also just like the treatment by the doctor, like they're just trained better. Like I don't know how to, they just know how to treat us with compassion and empathy a little better than a regular doctor, I find.
What does that look like, Ashley, being able to lead your own healthcare? What does that look like for you?
It's very freeing because before I was stuck just to like methadone, and then even my mental health meds were cut because of I was on methadone and I wasn't able to even get mental health care. So like that's been a big thing, is being able to like have a doctor prescribe medication for that, so I don't have to like use something else to substitute what I really need and what chemicals I'm really missing. I think that it's very freeing. Like I haven't ever had this like this experience with doctors, but at the same time, like you have your prescriber, and then there's the rest of the healthcare system that still needs to like catch up. So I think
Yeah.
that's where the gap is, but yeah, that's what it's very freeing.
Yeah. It sounds like within this, within the medical system that, can be so harmful, you at least had a team of people who, you didn't have to convince because they believe you, right?
Exactly.
I think, Liam, you may have raised your hand before Steve did.
Yep. I just wanted to say I've been on the safe supply for 3 months, and it's really it turned my life around. Before, I was always hustling, 24 hours a day, just to be able to score. And now it's like I don't have that pressure all the time on me, to get out there and make money and hustle and hustle and hustle. I can take, a week off and it's like, wow, this is a new feeling.
Mhm.
The only other thing that I'd like to say is about when I started the safe supply, the doctors are so much different than the doctor I had for methadone. I mean, if my appointment lasted more than 40 seconds, it was a miracle with the methadone doctor. And here I'm taught, I sit down for like, an hour. Like I'm asking to go, and it's just so much better. It's like they really care, what I'm saying. And I'm not just another, kind of dollar. Yeah, basically that's it.
Thanks, Liam.
You're welcome.
Steve? Thanks.
Yeah, hi there.
Thanks.
I gotta be honest, I wasn't paying a whole lot of attention what you guys were talking about. I'm sorry for that.
Benefits of safe supply.
Yeah, a million sorries, sir. But I need like the medicalization and the safe supply don't have to be hand in hand, you know what I mean? Like
What benefits have you seen from the program?
well, I've seen the benefits that most of the people that are on safe supply some of them use their safe supply to obtain fentanyl. There is a handful that it works for, that they use their safe supply as intended, but most of them.
What benefits are people getting from the program?
Well, stability.
Yeah.
Yeah, they
What
like it.
benefits are you getting, Steve?
What am I getting?
Yeah, what benefits do you see for yourself?
I'm gainfully employed. I have housing.
Faith in a doctor.
Yeah, like I have a doctor that's willing to work with me, like that I don't have to bullshit. You know, I used to go into doctor's office and tell them I want the opposite of what I really wanted, you know, like just to play mind tricks. Like, you know, sometimes it worked, sometimes it didn't. But yeah,
Thanks, Steve.
yeah, no problem.
Phoenix, did you want to say something?
Yeah, I just want to note, since we do have a number of prescribers in the room, when we do lie to you or when we do things that you feel are counterproductive, please know it's only because we're protecting ourselves. We're protecting what we have left that we may need to live for, our jobs, our families, our homes, our freedom of movement, our ability to be well. So, you know, you may hear from us that we have lied to prescribers or doctors in the past, but please know it's only to protect ourselves, because we've felt often in the past or even now that we cannot trust healthcare services. And I'm hoping that this dialogue opens some trust between the two groups. Thank you.
Yeah, thanks for sharing that, Phoenix. I think it's really important to note that, you know, currently Safer Supply exists within a medical model, but, you know, we've heard from some of the panelists that it doesn't have to, it's just that's what we're limited to right now. And so I think, you know, it's important to acknowledge that people find ways to navigate it in order to survive, in order to make it work for them. I think it is important that we're able to have, like you said, Phoenix, that dialogue and understanding and build that trust, because this is the system that we're working with currently. And, you know, it needs to expand, and we'll get into some of those ideas in just a bit. But I wanted to ask, I see your hand, Steve, but I wanted to ask Thomas if you had anything you'd like to say in terms of benefits of Safer Supply, positives that you've experienced.
Yeah, sorry. Feel like it centralizes a lot of things, like a lot of services that are provided are all in the same area now. And let's see, it's a good step in the right direction towards destigmatizing drug users.
Mhm.
It's
Yeah.
free and safe, and
Yeah.
Thomas,
do you want to talk about some, like, your personal experience with injectable hydromorphone?
Sure. In what sense exactly? Like,
just, you know, wondering if you have anything you wanted to add in terms of, you know, not having to rely on the pills, but having a formulation that's injectable.
oh yeah, okay. Well, I don't have to prepare it anymore, which is great. I mean, that was a big pain in the ass. It's more potent. I know where to get it all the time. It's always in the same area. There's no danger in me being robbed or killed by drug dealers or people surrounding drug dealers. Things like that. Yeah, I get to meet a lot of cool people, which I wouldn't have gotten to do before. Get to network a lot, and I have a job I like now for the first time in my life because of this place. So, yeah.
Thanks, Thomas. Yeah. Steve, I see your hand.
Yeah, sorry, I'm gonna bother you again. Thomas, if you're ever in Ottawa, drop by the Somerset West Health Center. if you want, and ask for Steve and Tara. Tara here is my coworker also, and she is in charge, the team lead of the Safe Supply. I'm on a Safe Supply with a different agency, so there's no conflict, right? Like my doctor is a whole different, it's a whole different clinic, you know what I mean? But fuck, I forgot
Sounds
what-
good.
I think you're just interested in now meeting with him because you liked what he was saying.
Yeah, yeah, and just like I'll just say one thing, like when I come on these meetings, I like absolutely don't lie. Like I wouldn't be like stuttering and kind of nervous if I was lying. I don't think, because when you know, it's just not something that I do. Like I don't have to. I've shot up on the street like corner, like rush hour, and had people take pictures of it. Like I don't care. I don't give a shit what anybody thinks, except for a few people. I do not lie. So yeah, that's, you know what I
Thanks,
mean?
Steve.
Yeah.
We've got some community connection happening here in the panel. It's awesome. Ashley, I'm gonna take you, and then we're gonna move on to the next bit.
Okay. I just think it's important to note that like people who go to jail and people who've been cut off of scripts, like it's really important for them to be able to have access to Safe Supply. And I think that it's really beneficial for Safe Supply to expand to meet those needs and to accommodate those folks. Just wanted to note that.
Mm-hmm. Yeah, I mean, again, that's a great segue into the next section because we want to talk about some of the limitations of Safer Supply. So definitely like getting access to it for folks who end up being incarcerated is an like immense challenge, right? Yeah. Yeah, so it's great that we've been able to talk for some time about some of the benefits of Safer Supply, and there are many, I think, as you can see. But we also want to talk about, you know, how Safer Supply needs to expand from what it is currently, and want to talk about some of those challenges that folks have experienced. So if anyone wants to start us off talking about some challenges or maybe some barriers you've experienced within Safer Supply.
Hi. I find that it's the amount of pills that I have to take to make myself feel comfortable is insane.
Mm-hmm.
So I think that it'd be great to get some liquid, whatever they want to give me. And a lot of people like trying to get people on it. There's not enough prescribers here in Kitchener to prescribe to all the people that really need the program. So I think that that's a huge like loss for a lot of people, right? Because as we know, the methadone rots our teeth and does all kinds of bad shit to us, right? Excuse my language. Yeah, that's about it.
Thanks, Angie.
Yeah.
I think Steve was next.
I'll talk.
Okay.
I don't mind talking. Like honestly, I've been addicted to opiates since like 17, 18 when I went out to Vancouver, and I came back a different person. Like, you know what I mean? You couldn't even get heroin on the street in Vancouver, in Ottawa back then, you know? And I managed to find the only 2 heroin dealers, you know, working in Ottawa back in 2001, you know? Lucky me. So anyways, and I've been in and out of jail. The first time I went to jail, the doctor at the jail, Dr. Tate at OCDC, didn't have a license to prescribe methadone because you needed one back then. Okay, so he cut I was on 220 milligrams a day of methadone, and he cut me down to T3 3 times a day, Clonidine 3 times a day, and Imodium, I think.
Mm-hmm.
Oh And
Juice.
Seroquel, something to,
Bug juice.
yeah, bug juice, exactly. Yeah.
Any limitations or things you like to see for safe supply?
I'd like to see safe supply. I'd like to see just like alcohol is offered in a fucking store. Like, you know what I mean? If you're of age and you can prove it, and like, you know what I mean? Like, if you know, with like large print of the dangers of, you know what I mean?
Yeah.
Of, you know what I mean? Like, you know, because there's a lot of ways to, you know, screwing yourself up with drugs. Like I have friends that like have tried to shoot stuff and now they're, you know, their limbs have to be amputated because they shot dope with some kind of bacteria in it, maybe, or they, you know, they let their abscess get too big before they went to get it lanced because it's a horrible thing to get an abscess lanced. It's like, I don't want to take away from childbirth, but it compares. I'm serious. And, you know.
Yeah, so what you're saying is right now people have to rely on, you know, the few prescribers that are willing to offer safe supply. If they need access to it, it would be great to see greater access, regulation, decriminalization. Yeah.
And yeah, like and like for myself, like I live an hour and 10, 15 minutes out of the city from my work. Like, so that's my drive. Like I have a pharmacy in town, but to see my doctor, it's a long drive. Like, you know what I mean?
Right.
And like, I'm not like, I don't know.
Yeah, there's an access issue, right?
Yeah, he like my doctor, like I'm saying this kind of wrong because he's the most low barrier. Like this guy's heart must be the size of the room I'm sitting in because he saves like too many lives, you know.
There's not enough of him.
Yeah, like he's an incredible guy. Anyways.
Thanks, Steve.
Yeah.
I'm gonna move on to Ashley. I think you're next.
So one of the issues I've had is like my tolerance going way too high, and then like nothing can alleviate any sort of like even tooth pain or like anything really. Like I can't even sleep no matter how much like even like adding street supply on top of safe supply. Like I got to a point where nothing was helping, nothing was working, nothing would make me feel anything. So I think it's important to like gauge those tolerances, and it's hard because like COVID kind of screwed with patient client relationships in certain ways. I know with mine, I didn't see a doctor for quite a while at the beginning of COVID, and I had too many meds, and it was detrimental to my actual like life and job and livelihood. So I think it's important to like keep a close relationship with your clients and know their needs, as well as like their lifestyle, because like we still have pain management needs, and if our tolerance gets too high, those needs aren't being met. So I think that's an important issue to like watch. Also,
so more support from the prescriber in terms of watching your tolerance with prescription. Okay. Sorry, you were gonna say something else.
There's like also like there's real access issues for folks who are like on res or like in rural areas. I think it's important to like prescribe. Like I'm close to res and I have to drive to Toronto, so I think like it's important to like have more community-based safe supply programs, maybe.
Absolutely. Yeah. I mean, I think it exists almost entirely within like urban city settings, right? And we can't forget about rural areas, and the need exists there just as much, right?
Yeah, and the medicine that from switching from fentanyl to Dilaudid wasn't a thing that was easy for me, and it still isn't. Like, so I think that it's important to meet people's actual like drug of choice. So I think that's an issue with the current state of safe supply as well.
Absolutely. I think Phoenix, I think you were next with your hand.
Yeah, so thank you for leading into that, Ashley. That's a brilliant point that I wanted to make is if we were to go now to prescribable heroin, it would be pointless. People's fentanyl tolerances are so high. If we had done prescription heroin 5, 6, 10 years ago when the need was there, that would have been the time to do it. Now we need to actually prescribe fentanyl in smokable, injectable, and all other forms that people use drugs. And I mean, as far as trying to provide stimulants in a medicalized model, it simply doesn't work to prescribe something like Dexedrine for a person who's a meth user, or like I am, a cocaine user. It doesn't work. We need to actually prescribe real drugs in real quantifiable doses that people can take. And I know that that's not in your hands, prescribers. Obviously, that's a thing that we need to work within the medical model with you guys to try and move forward. But really, the drugs that are being offered as pharmaceutical alternatives are not meeting the needs of the people that are using them.
Thanks. Yeah, Liam.
Well, I just wanted to say, when I first got on the safe supply, the Dilaudid did nothing. My tolerance was like through the roof, and so I started using the Dilaudid, the Hydromorph, and it had no effect. It was like nothing. So what I decided to do was to kind of go cold turkey on the fentanyl and lower my habit down to the point where I could get high on the Hydromorph. It was having an effect, but it took almost 2 months to do that,
Right.
To get to a point where the Hydromorph had any kind of effect on me. It was just piling everything on top of everything, and yeah, it was a nightmare. I think that when people get on the safe drug supply, they have to have certain goals, and kind of go for those goals, That's all I got to say.
Yeah. Not to put you on the spot, Liam, but do you have any suggestions for prescribers when it comes to that experience of the doses being incredibly low when people start? And
well, I think that you have to, first of all, you have to have a good communication between the supplier and the person, right? And you have to have goals. You have to have, what do you want out of this? Do you want to keep on using? Do you want to, do you want to feel euphoria? Do you want this, or do you want that? I think that's important, because if you're coming in with, and using 2-3 grams of Fetty a day, what the hell's 30 hydromorphs gonna do? It's nothing. So you have to kind of decrease one and increase the other. That way, at least it's effective. You know what I mean? At least it works. But to kind of compile one on top of the other, you'd end up having to do, 200, 300 hydromorphs a day just to feel anything,
Yeah.
So, Yeah, I think that the communication is the most important thing between the supplier and the patient, you know?
Yeah. And I think too, to connect what you're saying, Liam, with what, you know, Ashley and Phoenix have said too, is it's impossible to equate, you know, your street drug use with, you know, whatever replacement you're being offered in terms of hydromorphone, when the tolerance there and is just, it, you know, it doesn't exist, right?
Yeah.
So yeah, I think one of the solutions, or one of the ideas that comes up, you know, we're talking about buyers groups, talking about prescribing drugs like fentanyl and heroin, and having those prescribable alternatives. And I think, yeah, I think it's important to recognize that it's a start. Prescribing Dilaudid and Cadian is a start, but
Absolutely.
it's just a start, right? Like we can't just say like, we figured it out, we've done it, and then stop there, right? Like this is just the beginning. Steve, you've had your hand up for a while.
Hi. You hear me?
Yeah.
Yeah, like I said, it's like it would have been the perfect option 5 years ago. If you had told me 5 years ago, here's 30 days today, I would have thought I was in heaven. I won the lottery. Because I used to nod off 2 or 3 at a time, you know what I mean? And you know, but now 120 mils of methadone, 30 Dilaudid, and
Cadian.
you know, I'm trying to fill the glass half full, but it only gets 3/4 full, and I need fentanyl to make it all the way full, you know? Like that's the way that's my big analogy for for how it works, you know? Because I haven't been like I have, like, you know, I'm housed, you know, I have a great relationship. I have a good job. I work at a safe injection site, like for 3 years now. Like, and like, I don't know that, I know a few of the staff, but I know every single client almost that goes in there. They still ask me, you got anything, you good? You know? And I say, no, I work for the community now. You know? But yeah, like they're like, if the underground rogue chemists can come up with these super analogs of fentanyl, why can't big pharma come up with the fucking things? You know?
Absolutely.
Or why
That's a good question.
And clean, like, not, I don't want fentanyl with benzofluorazepam, fucking this and that. I don't want benzodiazepine. I just want fentanyl, pure fentanyl. You know what I mean? It's you know what I mean? It's a dangerous proposition. Like, and I'm not sure how to roll that out, you know what I mean? But it's no more of a risk than giving carries to methadone patients, because, you know, they're kids who go in the fridge and decide they're thirsty and see, you know, a bottle of orange juice and chug it down, and, you know,
you gotta teach people responsible.
Yeah, I mean, when it comes to carries, there's, you know, safeties in place to mitigate that, but I hear what you're saying, right? Like, we need equivalencies, and there are ways to do it safely, as safely as possible. So let's figure that out, right? Like, let's get there, because people need access to drugs of known quality and quantity that can match their tolerances, and we don't have that right now.
Well, we do, because like people are getting them.
Fentanyl's
like
everywhere.
You know, fentanyl's everywhere, and the fentanyl that's on the street, that's all every color of the rainbow. didn't start out that way. It started out being cut like 1 ounce to 20 ounces and then dyed a certain color, you know what I mean?
Mhm.
Like,
Fentanyl's already everywhere.
so if they can come up with that in an underground lab with a rogue chemist, as they say, like then I'm sure big pharma can pay more to these chemists to do it legit way, and
Yeah.
it's a cash cow for everybody. It's a win for us. As much as I don't like to compliment big pharma or whatever, like I don't think they're a good influence on whatever, but I think with their help, like, you know, they have the,
Solve the opioid crisis.
yeah, they created the fucking opiate crisis. They fucking so-called finished it, and here it is again, you know.
Thanks, Steve. Ashley?
I just wanted to note, like, for people who use like IV drugs, I think, like, for me, I'm allergic to Dilaudids if I shoot them. So I think like it's important to give people like pharmaceutical grade heroin, fentanyl, cocaine, meth, whatever they take, because like it's so needed. And there has to be a way to negotiate that and also negotiate for coverage, not just to have it, because that's not enough. We have to have it covered so that folks can access it properly.
Yeah. Yeah, 100%. Thank you, Ashley. I want to pose another question. Oh, go ahead, Phoenix.
Yeah, I just wanted to say on the coverage and prescribing issue, here is something actually concrete that prescribers should know and can do. When you are prescribing the hydromorphone, please make sure to specify that it is the name brand Dilaudid, not the generic hydromorphone, because if your clients are injecting, the name brand hydromorphone is the name brand Dilaudid is the only one that you can actually inject properly. The generic hydromorphones are too chalky. They have too much buff and filler in it. So it's really, really hard to inject those. They just suck all the water right up. So that's, and of course those are more expensive. So a lot of cheap prescription plans won't cover them. So that's just something that you guys should be aware of.
Thanks.
And it's dangerous. I have seen more than once, you know, an attempt to crush up the generics because they don't dissolve. They can and will explode in your face. And you've got extremely hot liquid exploding in your face. It is incredibly painful and incredibly dangerous. So yeah, it's an extremely good point. You know, it's a very simple thing just to make sure that when you send out a prescription, that you make sure to be clear that it's the name brand Dilaudids.
Yeah, they don't even work properly. Like they're not even as effective. They don't last as long either.
Yeah, they're garbage.
The question I wanted to maybe pose to the group is, you know, with this little bit of time we've got left before the Q&A, what would you like prescribers to know? And, you know, specifically prescribers who are not currently prescribing any safer supply, what would you like them to know? What are some things that you'd like to share, just in terms of like why it's important to take this on?
That basically there's a lot of money to be made, and the people making it now are like probably what quote unquote criminals. Like you know what I mean, like it's an underground market right now, and they could be capitalizing on all that cash, because at the end of the day, money rules the world.
But aside from the money, Steve, what do you think is so important about getting more people to prescribe safer supply meds?
Well, like, I don't know, have you, like, I work in a safe injection site, and there's days where we revive like upwards of 10 people a day sometimes. you know, and if they were not there, not with us, not, you know, not with someone who had a Narcan kit, they would just be a statistic. You know what I mean?
Yeah.
Which is what I always thought I would be until, you know, changes happen in my life and stuff, but whatever. But for someone to say there's no benefit to safe supply, like if I like could sit down and like actually get my thoughts together and present a case, like I could like I'm a case, you know what I mean? Like before safe supply, I didn't even live at the mission. I didn't even want to go into the mission and book in. I lived on the sidewalk in front of the mission because that's where all the, not the mission, we'll say, you know, nearby for quarters, the shepherds, anyways. But that's where all my money was, right? So, but this would make it so that I wouldn't have to, like, I could use my time to like pursue other interests and do other things, like you know, like I feel good. Like now I'm trying to do things that give back to like the community, like, but you know, I feel like it'll never be enough, like, you know what I mean?
Thanks for sharing, Steve. Phoenix?
Hey, so one thing also that is probably important for prescribers to note if you do start a safer supply practice or even just prescribing is at least in BC here, we've been facing a lot of pushback from the College of Pharmacists. A lot of doctors are worried about their licenses being at risk for prescribing off-label and for prescribing large amounts since the OxyContin thing has made people super scared of prescribing opiates or other controlled substances. So that's something that you may need to be aware of. You may need to take that on. It may be more stress for you and more work, but really we need it. If we could access that in a way that is workable for us, and I mean, not even your clients that you know are drug users, you probably have tons of other patients that you don't know are drug users who could, if they felt you were safe to approach and knew that this was something that you could do for them, they might approach you and you might help save lives, you might help stabilize families, you might help people keep jobs, you may have a hand in so many benefits for your patients that you may not be offering now. And it's just a matter of being approachable and reducing your own stigma. And when you see stigma coming, just, you know, challenge your own preconceived notions about what drug users are. I have been homed and I've had a job. I've worked since I was 13. I've used meth, I've used cocaine, I've used heroin, I've used everything. And I'm not a typical drug user from what people think. And so your patients may need this, they may not look like they need it, but whether they do or not, if it's something that you can offer them, I say go for it. But it may cause you a little bit of extra stress with your fellow prescribers or with the College of Pharmacists. But if so many of you speak out and do this, I don't think that they can stop us.
Thanks, Phoenix.
Thanks.
All right, Ashley, and then we're going to move on to the questions.
One thing I think is important is to keep a good relationship, have like a good, treat your clients like you would treat any other patient you have that doesn't use drugs, like be approachable, like was said, give wraparound care, connect people with supports, like be their like support person more than their prescriber. I think that's important. Like that's what I have and it's worked for me really good. Especially being a mom, like that's another thing. You have to be very careful with mothers who use drugs when you're prescribing for them, and really make sure that they're following a safety plan so that it's not detrimental to their family life and being criminalized in later.
Having their kids taken away.
Exactly.
Yeah, thank you. Thanks for sharing that.
Thank you, Ashley.
Thanks.
So yeah, we're gonna move on to the questions and answers section. For the attendees, there's a survey that we would love if you could fill out, just as a reminder. And I think the link to it is in the chat, if I'm not mistaken. Yeah, Alex has just added that comment there too. All right, so let's look at some of the questions. So what do you think is the most impactful way to advocate for safer supply? And then do any of the panelists have experience encouraging or establishing safer supply in their own communities? And if so, could you speak to the experience of advocating for it? So first part there is, what do you think is the most impactful way to advocate for safer supply? Ashley?
I think the most impactful way is to just be loud and like take it on ourselves as drug users, but also like with support from prescribers and pharmacists and like all the stakeholders. But like we need to take the lead as drug users so we can lead what the programming looks like and what things happen and like how things are formulated. Like I think that's important. So we have to take it upon ourselves, and then we need a lot of allies, a lot.
Mm-hmm.
And we need to be loud. But as for like establishing, like for me, I'm in a rural area and close to res, like it's really conservative and really hard to establish safe supply. And I think there's like there's like one prescriber here and one pharmacy around here, like so it's I haven't been successful. And even in Peel, like we cried to the council and they still haven't let us open a safe injection site. So I mean, like, so we need help. We need like prescribers to back us as well.
Yeah. Yeah, thank you. Phoenix?
Yeah, that's what I was going to say, is one of the things that prescribers can do to help us and to advocate is to just talk to your fellow doctors, talk to people in the healthcare community, reduce stigma in healthcare, talk to them about safer supply, get people interested in it, seek speakers to come to your places of work when you're doing professional development days, anything that you can do to get the conversation moving forward about safer supply and about anti-stigma. Because that's really the thing that keeps us from seeking care is, I can't remember her name and I'm ashamed that I can't, but there was a young woman who died in one of the maritime provinces a couple of months, maybe a year ago, because she was homeless and she was a drug user and she went to the ER so many times that they treated her like shit and she had sepsis and she didn't go. She said, no, they're just going to treat me like shit. They're going to kick me out. And she died. And we need to stop that from happening. And it was all just because she was a drug user and she was homeless. And so when you go somewhere that you're supposed to be getting care and they treat you like a literal scum of the earth piece of shit. Ashleen, yes, thank you. And so when that happens, it deters us from seeking care. So break stigma in your own communities, in your doctor communities, in your healthcare communities, and talk about safer supply. That's the thing that you guys can do to move this forward.
Yeah. Absolutely. Steve?
I'll say in Ottawa, what happened was the birth of like the established harm reduction or whatever was an illegal tent, pop-up tent that was an overdose prevention site. Like that was totally not legal. It was packed every night with people smoking crack and shooting dope. And this was completely like volunteer basis, like donation basis, like and it inspired it showed the mayor like how many people are gonna die. Like we just saved like three a night, like, or 2-3 a night. Like that's gotta make an impact. Those are even if it's one a night, like you just save that one person's life. You know what I mean? So if it wasn't for these places,
It gave you the sense of
you know,
community again.
it's life or death. It's not like breaking the rules and paying your penance anymore. Like most addicts who've been at it for a while know how to do time, and they've, you know, like it's not a big deal for them. They're used to it. But most of them also don't want to die. Like they don't want that their legacy, like to be found in a bathroom stall with a rig in their arm. You know what I mean?
So what would you like that to look like in terms of safer supply, Steve? Like how can we get that sort of
Okay.
model to work for safer supply?
Well,
Sorry?
I'm not a doctor, so I'm telling you, like, in terms of like what led me to it, like I had no use for safer supply or OAT or nothing. I got off of it a long time ago, and I made it. I didn't put it on anyone else. I like made sure that I, you know, like had the contacts and whatever you want to call them, that I managed my own problems. You know what I mean? I didn't.
But then you found one doctor you trusted.
Yeah, but yeah, it was all drug addicts, ex-drug addicts, volunteers, nurses who had interest in harm reduction that started these tents.
Safe supply though, not the injection sites. How would you encourage safe supply, like that sense of community, like
Sense of
treat drug users like people?
Safe supply was what me and my friend here drove up to Toronto for a conference on safe supply and got all the details, all the contacts, all the information, and brought them back to my doctor who listens to me, that we have a very transparent relationship. You know what I mean? He listens to me, and like as I told, like, and he was willing to give me a shot. Like he said, he read that people were doing this in London, in Toronto. Like I think you've heard the name Andrea Sarita. Yeah. Okay. Well,
So get information, bring it to doctors.
yeah, we got the information. We brought it to the doctor that we thought would be open-minded about it, and he was. Like, you know what I mean? And
You're alive now because of it.
yeah.
3 years later.
Yeah, I'm alive. Yeah, like I don't know what else. I had something really important that was going to come out, but
I can come back to you, Steve, if you want.
Your memory is like totally fried.
Been a fucked up couple
That's
weeks.
okay. Just you can raise your hand again if you think of it. But I'm going to move on to Thomas. Thomas, you got your hand up.
Yeah. Oh, I think I don't know how you would go about doing this, but I think a great idea or a good idea would be to provide some kind of simulation for people who haven't used drugs, like for doctors or nurses and the people providing the drugs, like a simulation of what it's like to be an addict. So, you know, they'd understand the need people are facing every day instead of just judging them all the time, kind of thing. I don't know.
Yeah, so more awareness amongst prescribers of what experiences drug users have to go through, right? Navigating the medical system, navigating, you know,
Yeah.
street supply and having to rely on it just to, you know, survive the day, and being able to share those experiences. Am I getting that right?
Yeah.
Thomas?
But like even more so in some way. I don't know how you do that, but yeah.
The next question is about, let me find it here. So between our current model of prescribers practicing safer supply and compassion clubs and buyers groups and that kind of model, Do you have any suggestions of something that's somewhere in the middle of those two models? Is there any suggestions between our current system and, you know, suggestions around compassion clubs and buyers groups? Ashley?
Personally, I think we need all of them. Like it's not something in the middle, like maybe like through like asking the communities in which you live and work what they need. Maybe that's where you come up with that middle ground. But I know the more access to service, the better, and the more that's available, the better, because like some people like going to the doctor and getting a script, and some people like going to compassion clubs, some people like shooting up in SCSs, some like shooting up in their houses. Like everyone is different, and we need to accommodate for everyone's individualistic needs.
Thanks. Steve?
There you go.
Okay, where were we at when I raised my hand?
It's something in between the medical model and the
Yeah,
buyers club.
something between the medical model and the buyers clubs. Well, that's what we're in right now. That's the situation, I think, right now.
Suggestions.
Either you can find good dope dealers, but you still don't know, even if they're ethical and good people, you still don't know what's in their drugs, and they don't know what's in their drugs. They can't guarantee you that it doesn't have this or that in it, because you know what I mean. And then there's the medical model that's like, I've seen all kinds of ways that you know mixes up people's lives, and like I've seen it better a lot of people's lives also.
What would a middle style model look like in between those models?
A middle style model would be for like, once a person gets to 30 D8s and 100 and something of methadone, and says, doc, like I don't want the extra four D8s a day, because they're not going to do anything. Like if 30 is not going to do it, 300 is not going to do it. You know what I mean? So do you have anything else for me? Like, and then, you know, just, I don't know, slide him a card, you know, or call this guy, maybe he can. I don't know.
That's cool. I like that idea.
I know,
Like
no doctor is going to ever like hand out a drug dealer's number to their patients. That's not realistic, but
it'd be nice.
you know,
But
compassion.
have more options, right?
What's that?
But you're saying that there needs to be more options just beyond what we have currently and buyers clubs, right? Like there just needs to be more. Am I hearing you right?
There needs to be like more drug checking.
Yes.
Like at every SCS, every single SCS. Before you go in and inject it, you take a small piece of it under the whatever mass spectrometer, and you find out what's in it. Is there xylazine in it? No, I don't want it. Take it back. You know, is there fucking benzos in it? No, I don't want it. Take it back.
And there's some dealers that give a shit. They'll try and like if they knew what was in it, like they could change what they bought. Yeah.
Okay, we've got quite a few more questions. So I might, Phoenix, if you wanted to say something quick, we can get to the next question.
So about drug checking, I mean, I was a drug checking technician for months, almost a year at the OPSs. And the problem with that is people spent their money, they bought their shit, no matter what you tell them is in it, they're gonna do it, especially in a drug use environment like an OPS. And as for a middle ground, I think doctors, prescribers, and healthcare workers getting involved with compassion clubs and being there as a medical consultant and being really involved in those communities could be a workable middle ground. Thank you.
Thanks, Phoenix. The next question, can I ask opinions on decriminalization versus legalization? I'm feeling stuck as a person trying to help on the medical side of the system. With decriminalization, how can we best address toxic drug supply? And with legalization, how can that be safe for people who use drugs to have trust in the system, who have been oppressed from criminalization and stigmatization from the war on drugs? Liam? Yeah.
My view on it is I would like things to be legalized. I don't see why everything shouldn't be legalized. If you're old enough and that's the route you want to take in life, you know, why not have the government supply it? You know, it costs them nothing. They would be able to control it all. All of a sudden, you wouldn't have people going to jail for any kind of drugs anymore. Maybe for impaired driving, but not for drug use. Right now, I mean, you know, how many people are in jail just for being a drug addict? You know, you know, if it was legal, there wouldn't be all that stigma attached to it. You know, people would be a lot more open about it. I was in Germany, and they have a heroin program there, and you know, it was just, you know, you could go in and be on a heroin program in an hour. You know, it was crazy. And yet over here, it was at the same time, it was just, they had a waiting list to get on methadone.
Yeah.
You know, I couldn't tell you how many friends I saw die. This is like quite a long time ago, but you know, it was just crazy. You know, they have decriminalization in Portugal, and it works and it doesn't work. But I think my personal view is I think it should be legalized. Everything, anything, you know.
Mm-hmm.
Thanks.
Thanks, Liam. Sorry, Steve, I'm going to move on to the next question because there's quite a few to get through in the next 10 minutes. So the next question is, in London, there's a major wait list for our safer supply program, as there's not enough prescribers, and we are in the works of trying to expand the program. Therefore, the wait list is extensive and wait looks like 1 to 2 years at this point. Do any of you have experience being on a wait list before you got onto the program? And what can workers do or say to support folks while waiting? Has anyone experienced that? Liam? Yep.
Yeah, I experienced, what happened with me is I had signed up, or I'd signed up or talked to people about being on the, getting on the safe supply. And the evening before I was supposed to get on the program the next day, they canceled it. And I had to wait another 3 months. Which wasn't a long period of time, I guess, in the whole aspect of things, but it was, you know, I couldn't tell you how many people I saw OD in that 3 months. Luckily, I wasn't one of them, but I finally got on the program. You know, it was really frustrating that I had to wait. Thank you.
Steve, you wanted to say something?
Yeah, what was I gonna, first of all, like they were ODing on what, on illicit drugs from the street or on their safe supply?
No, on illicit drugs.
Okay, that's what I thought. So once you got on the safe supply, the ODs stopped.
Yeah,
right?
yeah.
And like in our town, I don't know about anyone else's, an 8 milligram Dilaudid used to go for $15 to $20 a piece. Now they're $1 a piece. So
Keeping a lot more people alive on that wait list.
you know what I mean? Even if you're on a wait list, if fentanyl is your kick, then it's always going to be your kick. But if you really want to be off fentanyl, then there's Dilaudid to go around. Like you'll find Dilaudid in a city if you're looking for it. You'll find just about anything, you know, if you look hard enough, you know what I mean?
Okay, Steve, I'm gonna move on to the next question. Again, I apologize, just trying to get as many questions answered. Hi, I wanted to ask what kind of social support services are helpful or not helpful along safer supply? And do you feel that they're needed as part of safer supply? Ashley? You're on mute, Ashley.
Sorry. So I think I'm like a child welfare apprehension abolitionist pretty much. So I don't agree with any contact with CAS, but I mean, like, it's kind of forced right now in a way. So it's that's not good. But like, I don't believe we should have police outside. Like, that's intimidating. People won't want to come in to like see you and won't feel comfortable if they always see police trying to like move people along outside of your service. So I think that's important, like keeping the outside free of cops, a safe space, and like somewhere where folks who use drugs want to go.
Yeah, thanks. Phoenix?
So I think that wraparound supports are really important. The main problem is if you make them mandatory, some people may not need everything that you want to offer, but things like nutritionist support, mental health support, many of us are coming from backgrounds of extreme trauma. We need counselors or psychiatrists or things like that to be offered. Anything, you know, like some of your clients may need help finding housing. Some of your clients may need help, you know, in lots of different ways. But the main thing is to tailor the approach to each patient and really make sure that you're not forcing anybody to be involved in anything. Like if I had to do counseling to get my safe supply, I wouldn't want it. But conversely, if it was offered to me, I may take it up. And you want to be really like accommodating. Some of us can't make appointments. Peer support workers, absolutely. Having people who use or use drugs in your facilities to navigate these incredibly like confusing processes, helping people fill out forms. There's a lot of literacy issues, helping people navigate these steps that seem, you know, rote to you because you've done them 1,000 times, but to us, it's like, why do I have to go back downstairs, then come back upstairs, then go back downstairs, then go to this other place 3, you know, miles away across town? Many of us don't have transit or any sort of things like that. And especially in rural, remote, I'm not qualified to talk about that, but that's just an even worse nightmare. So really having peer navigators help out and really tailoring the approach to each patient, see what they need, ask them what you can help them with, make those connections.
Thank you. Yeah.
I
Ange, I'll take your answer, and then I think, and I have to apologize, I think that'll be the last question that we answer.
I think the support team is a great. It's great. They've helped me. If it wasn't for them, I probably would not be on the program. I probably might even be dead if it wasn't for my support team. So I think that they're amazing, and we need them immensely. So yeah.
Thanks, Angie. Yeah. Thomas, did you want to share something? I saw your hand was up.
Yeah, I just feel like there's a lot of people who don't know how to articulate the problems they're having. So it'd be good if somebody could act on their behalf in terms of support, I guess. That's all.
Thanks. Yeah. I mean, it can be quite overwhelming. So it's always a good thing to have support available, but not mandatory.
Yes, absolutely.
Again, apologies for not being able to answer the rest of the questions. But thanks everyone for attending.
Thank you.
Alex, do you want to wrap up?
Sorry, I think that was totally my fault. Probably to a certain degree that you didn't get a chance. But, yeah, but I could talk about this stuff for days and days and days.
I think we all could.
Yeah. Yeah, no, Steve, I don't think it's your fault at all. I think it's just we all have a lot of questions. Wow, I'm incredibly just astounded at how fast the time just passed there.
No kidding. No kidding.
That was really, really awesome. Can everybody see my screen again?
Yep.
Yeah? Like the PowerPoint part? Okay, cool. I just really want to thank you so much. Thank you, Frankie. Thank you for your incredible moderating today. We really, really appreciate it. You just bring so much nuance and so much like love and compassion in the way that you like are kind of steering a ship here. So I just wanted to send my gratitude to you, and then to all of our incredible panelists. I'm just seeing like thank you after thank you in the chat right now, and just how deeply necessary this panel conversation was. And I really want to say this won't be the last conversation that we have that is like this, that is really centering the voices of people who are participants of programs. And so I want to encourage you all, so that you don't miss our next panel, to follow us on Twitter, follow us on Instagram, follow us on Facebook. My colleagues are going to pop the links in the chat there. We also are going to launch a very quick poll before people cycle out here. If you don't mind filling out a quick response sheet just for like how you found today, what worked for you, what didn't, and the kind of other support that we can give you in the future. Also, just wanting to remind folks that you can always go to our old webinar recordings. So we have one on emotional harm reduction. We have one on Safer Supply 101, kind of a nice intro, backgrounder kind of webinar. And then we have one about uprooting medical violence from NSSCoP, which all of these webinars are like really, really incredible, and they're not going anywhere. They're going to be on our website. So Robin and Full are putting the links in there. We also have some stuff that is just reserved for members. So that's like kind of our incentive. That's our way of trying to get you to join us. So please do put your membership in, and then you'll have access to, for example, on December 16th, we're having attention of providing a medical model for safer supply. So this is actually a group of prescribers that are going to kind of be having this conversation, but in a bit of a different context and perspective. We also have a bunch of other stuff to offer folks. So our prescriber line is currently working for members who are registered members and are prescribers of safer supply programs. We're also in the plans of making a bunch of different working groups. So I'd encourage you to go to our website, go to our social media, check us out. Veronica, I see your question about how to become a member there. We're going to pop a link to how to join in the chat for you. There it is. Thank you, Robin. And yeah, I think with that, I'll say thank you so much, everyone, for taking the time to do this. It's so appreciated. And I'm going to stop sharing now. Paula, I'm not totally sure if you've already launched the poll or if I need to launch.
I have. So.
Okay, you have. Okay, cool. I think it's because I can't see it because of my screen. Yeah, there it is. Okay, there you go. Okay. So I'll say thank you, and I think we're okay maybe to stop recording now, if that's all right.